This is what the drain looks like right here. And there's two ways to actually manage a lumbar drain. And it's going to depend on the surgeon. And so that there's another variable right there. There's a select group of people that just want to see volume, meaning a select amount of CSF over a time period. And then there's also people that will write the orders for a pressure setting, right, which is this sliding scale. There's a gradient scale here. What Dr. Pelosa wrote and what we're going to go over today, and then we can talk about the volume. The volume method is very simple, right? It's every 8 hours you're taking off a certain amount, and it's cut and dry. And that's, you open it up, the chamber fills up. When you get to whatever it's written, every, let's say 40 mLs is a pretty common thing, then you shut it off and you're good, probably for the rest of your shift, and you don't really have to mess with it. The pressure setting, which is something, particularly if you have a dural leak, right? So in most instances, something is going on with the patient where they either have increased ICP, which is the pressure of your cerebral spinal fluid, or there's a leak, right? Most of the time when you see somebody, something has happened in surgery, there was a revision, there's a small tear. Now they want to relieve some pressure on that little seal, right? They put a patch, they put some sealant down, and they don't want to have a whole bunch of CSF pressure pushing against that patch as the body's trying to heal. And that's all they're trying to do. Typically what will happen is patient will come with a Foley, because standing up, again, is working counterintuitive for both the drain and for the patch. All that pressure in your spinal canal pushes down due to gravity, and now you get a patient having unbelievable positional headaches. They stand up, the room starts spinning, they have a headache like they've never had before, because that pressure is now opening up either the drain, which could happen, or the patch where they have a dural defect, right? So for the most part, you're going to have someone have a Foley in, and they're not going to be ambulatory and whatever else. If they are ambulatory, the one thing you want to know is if they're going to the bathroom, no matter what kind of drain they have, no matter what's going on, you want to shut it off before they stand up, right? Again, because that gravitational push in the canal can cause extreme headaches. It's a risk for falling. You just be aware that standing up is not something that you want to take lightly with a lumbar drain. So orders get written. Normal ICP, every one of us in here has 120 millimeters of pressure. That's water. So that's basically the pressure that you have on it every day. When you sneeze, it elevates. When you stand up, sometimes it elevates. But in general, 120. So typically what you see, like in Dr. Pelosa's case, he wrote it for 8, right? Which is a little bit below, so that if you think about it in the true hydrodynamics of, it's a sprinkler head, right? This valve, or this drain opens up when a certain pressure gets to be a certain area, just like a sprinkler head. You turn the hose on, the head pops up, water pushes through. Same thing with this drain, and it's just a gravity thing, right? So when the pressure gets to be too much, this pathway starts flowing, right? Just like a sprinkler head popping open and relieving pressure. And that's all this is doing, and that's kind of the simplest, easiest way to think about it is, it's just a pressure release valve. So whatever this is set at, whatever the orders are, that's the surgeon saying, I want it at this pressure, I want it to be this sensitive, I want it to be less sensitive if it's lower, and I want it to be more sensitive, meaning less CSF moving through if it's higher. Sometimes you'll see them wean it up, right? Day one, they want to have almost no pressure against that patch as the body's healing itself. Day 2, they might raise it up a little bit. Day 3, they might raise it up a little bit more to see how they tolerate it. Are they getting headaches, whatever else? And that's kind of the weaning out process. So, patient comes from the OR. They've got a lumbar puncture site, which is important for you. It's usually got a tegaderm or some sort of packaging or taping over it. But that's important for you because that is actually the 0 reference, right? So you'll see here 0 right here. And typically what happens is you want to keep that, as they're lying down, you want to keep that in line with the puncture site, right? Because that's basically the frame of reference for how much pressure it's going to take to open up the drain.
So your IV pole, you guys, won't be at the head of the bed like you normally think it would. It's typically going to be coming out like
kind of right at your waist.
About a quarter of the bed down.
Right. So this will then, And this has got a laser level. This is primarily, so this drain is actually double duty. It's primarily a ventricular drain for people that have, oh, perfect. Yeah, that'd be great. Thank you. It's primarily a ventricular drain, right? So in that instance, this is actually leveled up. Instead of the 0 point being the puncture site, it's actually the foramen. And the exact same principles apply. It just has wherever the drain is at in spatial relations to that zeroing point. But for you guys, obviously you don't do cranies, you're not going to be seeing it. It's the zeroing point is the puncture site. So it's zeroed out, and then whatever the patient, or whatever the surgeon wrote the orders at, let's say 8, right? For example, that's a pretty good one. There's mercury and there's water. Mercury is a European thing. You won't, unless you have somebody that just kind of flew over for the day or whatever, you won't use mercury, you're going to use water. So that's centimeters of water. This comes down, you can see this is actually your reference point right here. So you would line that up with 8. And then what's happening here is this is staying in relation to the puncture site. And this, you can see this chamber is just, if I were laying perfectly horizontal, this is just a little bit taller. And that gravity push, just the spatial relations there, is what actually determines the flow rate. So all of the stopcocks in that scenario would be open, right? I know there was a question earlier with the patient that we just had about whether to keep it open, whether to not keep it open. The safety valve, in essence, is the setting that it's up higher, right? So that gravity is actually your friend causing a resistance, and then that's why you see a drip. Now, if this were to hit the floor, obviously, it's a free-flowing drain, and that's a problem. But everything stays open in the pressure setting scenario. Now, if you have another surgeon that is going to manage a lumbar drain and he just wants volume, in that scenario, once you get your certain volume, he wants to take off 40 mLs today just to relieve a volume out of the pathway. In that scenario, then you turn it off, right? But you're not in that setting. You're not worried about spatial relations. You're not actually worried about this. All you're worried about is this. One other thing to note, it's a little bit easier for you guys to manage, particularly because it's away. It's going to be at the waist of the bed. But one thing to note, this was designed to jump out at you, this blue line, and this is a CSF pathway, right? And it should kind of look different than anything else, because all of these stopcocks, whether it's right here or whether it's right here, are off limits in terms of, occasionally you'll have somebody say, I want to send something to the lab to check for meningitis, check for whatever else they're looking for. But in general, this should jump out at you, because what you want to avoid is you're working a double, you're tired, there's a bird's nest of tubing, you're pushing meds, and you inadvertently push this, and that's a CSF pathway, and that's a life-changing moment for a variety of people, right? And so this should jump out at you at all times, right? Once in a blue moon, you see how it happens when there's a bird's nest of IV tubings and the buzzers are going on, you gotta get to another room, and typically it's more of a ventricular drain thing that they're concerned with because it's at the head and there's a bunch of tubing. But just be aware that this blue line right here is meant to kind of look weird and jump out at you. Like, we're never pushing meds down through that. Patient transport. Occasionally you'll see orders get written quite a bit for a CT, right? Every day they're taking a look at either the dural defect or the whatever spinal construct. When a patient's getting transported, again, because you're concerned with the relations and you're not taking the IV pole to the CT, typically in most instances you lay it down, you'll turn it off, right? And the best way to do it is to turn it off closest to the patient. Just turn it off. It doesn't hurt to turn off it's a little redundant, but it doesn't hurt. There's a stopcock here. You can't hurt by having both of them off, right? Because again, if it were to fall here, you're in essence mimicking a bad dural leak, right? It's now free flowing, and you're going to do it. Usually, you see these run for 48 to 72 hours. I think Dr. Pelosa you guys took it out on Thursday and put it in on Monday. That's pretty much the longest you'll see it. Taking it out, couple things. Typically, surgeon or Matt, Dr. Pelosa's coming up here. or if he's getting ready and he says, hey, I want to take this out, if they don't have a Foley in, first and foremost, they should go to the bathroom, right? And the thought process on that is, once it's out, there was a little trocar that put in this catheter into that space. So in essence, you've made another puncture hole in the dura. It takes the body a little bit of time to heal, and what you don't want to have is they've pulled this out, that puncture site's kind of open, it's trying to heal itself, but as luck would have it, 20 minutes later, she had a whole bunch of water, now she's got to go to the bathroom. She stands up, and now you've got another dural defect because that spinal canal and gravity and push. So if they don't have a Foley, if they're taking it out, you want to have them go to the bathroom, because once somebody, whoever that person is, takes it out, the orders are 6 hours horizontal, no getting up, nothing. Typically, they'll go on their side, they'll put their knees up to kind of just give ease of use and relieve any pressure, particularly just even on the back muscles, and then they'll pull it out, they'll look and see, make sure that they actually see the tip. There's a little black graphite on it, that nothing got left behind. Put a Tegaderm or a Band-Aid over it, and that's it. But again, from there, the clock starts, and they're not to get out of bed for 6 hours.
I have a question.
Sure.
Because I took care of that patient last week, and the order there was every 1 hour we have to drain 4 to 5 ml.
So, and therein kind of was, that was a little bit of a curveball. So Matt just wanted to see how much was coming off, right? To make sure that there was enough coming off, because they weren't sure in terms of the volume, right? Set it at 8, and the initial that night, right? It was put in at 4 o'clock on a Monday. That night they wanted to see, well, is 8 too high? Is 8 too low? It was a little bit of a guessing game, like it would be with anything, right? You're kind of trying to find that sweet spot. So he was just wanting to make sure that there was enough CSF coming out. But again, the orders were written at 8, which is what you wanted. And I think the redundant order for volume is confusing. I mean, it was confusing to me when you guys called. I was like, yeah, and then I texted Matt, and he was like, I just wanted to make sure that things were moving, right? That 8 wasn't too high, and that also that it wasn't a tsunami of CSF, and 8 wasn't too low. So I think that was kind of more of like a belt and suspenders. Like he wanted to make sure he had orders written at the pressure, but also that that somebody would get a call, either he or Dr. Pelosa would get a call if it either wasn't dripping or it was dripping, you know, an abnormal amount. And that's kind of where that came from. But that's a good question.
So we're supposed to stay there till we get the proper volume?
Typically, if it's written at a pressure, no. Because it's just a real subtle drip, right? Again, it's gravity that's creating the check valve, and just like the sprinkler analogy, when the pressure gets to be below that because volume has been bled off, it stops dripping. The valve's down, or the gravity won't let it open.
Yeah, there's one time when it like I put out 11 cc in 1 hour.
Okay.
So that's too much.
So then you would try to raise the pressure to.
I think in that scenario, you 11 cc in 1 hour, typically it's gonna plateau out, right? So maybe it was off. Maybe she just had a spike, and then it can't run like that forever, right? Just sheer volume. So usually you'll see it plateau out. I probably wouldn't be too alarmed at that. I thought he was going to write the orders, 8 centimeters of water pressure, right?
Yeah, it was.
And then if it's over 30 mLs, then he or Dr. Pelosa would get a call.
30 ml in 4 hours?
Usually a 4-hour period, yeah. But again, we're more worried about pressure, right? As long as you're still up here, you really can't get yourself into trouble because your pressure is just slightly below normal. So you're just weaning off, and you're taking that pressure off that patch.
Can you show them how to move the little pressure
Sure,
valve?
yeah. Let me actually, this one's a better one. This is kind of,
And let me just say, the orders with the last patient was a lot of confusion. Around this was a lot of confusion. So we're in the process of developing just one order set, so everything is consistent, and they can't free text, make it confusing where we're running it both ways. they have to order it a certain way, so there's no confusion. Still
And
working
we
on
will also say, in the policy, it does state that, when you walk away from the lumbar drain, that it is to be closed.
Yeah.
Also, in your charting, it will ask you, did you close off the stopcocks and the
Uh-huh.
valves before you walked away? So,
Yeah.
this is one of the first drains, and this is why we're doing this in-service, and then Kara and I, probably in another couple weeks, will be doing some more,
Well, and that's
in-depth
and
education.
that's more of a somebody's written the orders for volume, right?
yes. Mhm.
And then obviously you would want it closed, otherwise
Uh-huh.
it's free
Yeah.
flowing.
Exactly.
Because in that scenario, when you're taking off volume, this is an old school volume one right here, right?
Right.
Uh-huh.
There's no spatial relations, there's no scale,
Typically
there's
put
no
it to the
gradient,
on
there's
the
nothing
ground.
else.
Yeah.
You put it down here, and when it gets to a certain thing, you just close the stopcock and away you go.
Yeah.
And I was telling somebody about it's not our product, but I think it's a great product. There's a Limitor.
The Limitor.
Yeah, I think it's. I don't know if
That's
you've
what
seen.
I've used before. Yeah.
Okay, and I think it's a great product, right? Because it's set it and forget it. It's got an
The
automatic
Veratrol's
flow.
only 30.
Right. It's
So
got
the
automatic
off
flow,
valve.
almost like the back of a toilet float kind of thing, where it just shuts off once the float gets to a certain level. That's a great way. If you're going to manage volume, that's a great product. If you want to manage pressure, you got to use something like this. And again, that's kind of a surgeon preference thing, how they want to manage it. Is it something that you're just trying to relieve? Typically what you'll see pressure more frequently if it's going to be a long-term thing, right? Because taking volume, there's big peaks in value. So if you think about just any sort of pressure against a patch, and you take all the volume out of the balloon, but the balloon's going to fill up again. Well, there's these huge peaks and valleys, as opposed to having some sort of regulator where the balloon stays at a certain level, right? And then that way, typically people do better if they're going to be managed for 48 hours. They do better with pressure, because then there's not the big peak and valley. Because if you drain off 60 or 30 or whatever on your first of your 8-hour shift, and you just turn it off, and you're like, good, I got my 30, I'm good. That's this is now the night shift's problem because I'm good. Well, what happens the other 6 hours?
Mm-hmm.
There's pressure building up, and now that patch is actually under significantly more pressure. So a lot of times people like this because it's going to relieve. It's just a pressure release valve.
And it has to work to go. I mean, it's going uphill.
It's going
like
uphill.
The tubing is uphill.
So this is the way it goes, right? So it looks here. It starts here. This little laser light helps. Some people don't need it. Some people do. Laser comes. You would want to see that laser on if I was laying horizontal, right? Let's say this is our patient. This is actually pretty good right here. Right, lumbar puncture site, right there. We're lined up right there, lumbar puncture site, and it's written at 8. We're going to slide this down. Again, this little, I'll spin it around. So let's say we're zeroed out, and it's written at 8 right here. So we're at H2O, we're at water, right? 8, and we want it to line up with that. We lock that down, and then now what's happening is, because this is the 0 point, right? It's got to go uphill, and gravity is your kind of regulator, which is why this is just a perfect graduated scale, and it just fights gravity. And when it gets to a certain pressure, it can get over that hump.
And I want to point out too, guys,
What he's talking about, the pressure level is right here. It's not according to the dial up here, right? So when you see the line, that's where you want that pressure level to be. Because I know a lot of people would move it up and down for the little dial to be a beat, but it's not supposed to be.
Then this is what's coming out of the patient, right? And again, blue line jumps out at you. There's a stopcock here, and then there's a stopcock here, right?
So I guess we have to have 2 policies for the volume and the gravity.
ideally we are trying to get everyone to go towards volume. I think this was Dr. Pelosa's first. He told me lumbar drain in about 5 years. So obviously there's new things coming out. So when Pat had talked to him, because Pat graciously came upstairs with that patient, he gave him the options, and Dr. Pelosa chose pressure for that particular patient. Ideally, what Kara and Krista and Kendra and I talked about yesterday is that we would prefer the patients to be volume so that you're closing the stopcocks before you're leaving the room.
So we're going to use the old method?
No, we'll still use this one. We have, these are the ones that we have in stock. So we'll still be using these. regardless of whether it's volume or not.
So the intervention is still the same, like
You don't have to do any math of, oh, well, wait a minute, when I at the start of my shift and look back through nurses' notes or do whatever else, whatever timeline you're managing this in, 4 hours, 8 hours, whatever, you just fill this chamber up. When it gets to be where the time you're going off shift and you got to transfer over patient and give report, whatever else, you're going to say, okay, we're at 40, we're at whatever amount it is. Clear this out, open it up, gravity's going to push it all the way down into the bag, close it back off, and now you have a graduated cylinder that's just back at zero, right? And then you don't have to do, I mean, if you're managing them for 72 hours, that's a lot of math. Well, yesterday it was at 4:20, now it's at 5:30, and then today it's at 6:10. How much, you know, in what timeline, whatever else. You're just using this graduated cylinder as your collection chamber. It can get wet. Sometimes you'll hear that. If the patient were to get transported to CT and there's CSF in here and you don't want to, you actually want to lay it down. This filter here is Gore-Tex, so it can get wet. That's just, occasionally we'll get that question. Any other questions?
how often do we need to check it? Like if everything is doing fine.
I mean, I guess how often do you do like your nurse's notes on?
Well, on the
Blood pressure
intervention
or
is
whatever.
like every hour.
I think probably put it in sync with however you do vitals or blood pressure and whatever else. I mean, that's kind of you guys' internal thing. Most people will do either 2 or 4 hour increments of just to see how it's going, particularly if it's at pressure. Because again, if it's at pressure, you're set, and you've got the safety valve of gravity pushing against it. Where if it's flowing too well, that's probably a good thing, meaning that there's something going on within the body that they have all this CSF pressure that's kind of, you know, causing a spike in ICP. You see it more in cranial, like if somebody's had a cranial surgery and their body's almost in shock and they're overproducing CSF, it'll be dripping pretty heavily for 24 hours.
So for example, on that one time when we have 11 cc, I will drain it to the bag and then wait again for another hour.
Well, however, whatever your interval of charting, I mean,
yeah.
that's kind of whatever you're putting in. Every 4 hours, I want to put down how much has been pulled off. Whatever your policy is, but this chamber just stays in sync with that, right? So if it's every 4 hours, or if it's every 2 hours, or if it's every hour, you come in and you say, patient produced 13 mLs of CSF. Okay, perfect. You chart it, you open this up, and you restart, you zeroed this out.
Yeah.
And typically your order is going to look like every hour drain 10, or every 2 hours drain no more than 20,
Right.
something like that. So it'll give you a. That's why CARE is building the order set so that there's time frames, volume, and so we won't have any confusion.
And it's a hard thing because again, you guys do it once every 5 years, and then there's also 2 ways to write the orders, and
Right.
there's kind of 2 thoughts of 2 schools of thought,
So
and
we're trying to streamline.
that's a challenge. Yes.
And that's your intervention is set for every hour simply for that reason that this is such a high acuity, low volume intervention for such a sub-select group of patients. The last thing we want is for, you look at the drain in the morning and then 6 hours later you go in and look at it. You know, so at least every hour
Every
you should
hour.
be laying eyes on that drain.
Yeah.
Do you guys have any other questions for Pat?
Yeah, tell us which port you use to